Hello there, healthcare humans. Thank you so much for coming back for another episode of The Other Human in the Room. I'm extremely excited and a little like podcast starstruck by the guest I have today because your podcast was one of the first medical podcasts I ever listened to, actually. And it helped me so much, especially when I was first like graduating from residency. It gave me a perspective that I really needed at that time. And so, James, would you like to introduce yourself to
Yeah,
everybody?
sure. Yeah, I'm a professor with the Faculty of Pharmaceutical Sciences at the University of British Columbia, which is how I start off all our podcasts when I do them, for people who've listened to them. And we started to do a podcast 15, 16 years ago because we thought it'd be a great way to just disseminate information and basically talk with two people, I guess, and let them know some of the things we were thinking about yeah, so that we just put it together because we realized that there needed to be a primary care voice and there needed to be a primary care evidence-based voice out there.
Wow.
And myself and Mike Allen, who co-hosts with me, we had been teaching for years about all this sort of stuff. And we said, well, why not try podcast? First, I had to explain what a podcast was to Mike. No, just it wasn't quite like that, but we figured we were going to do like 3 podcasts, and then we ended up now we're at episode 560 something or other. So
Oh my
we've been
gosh.
doing it a lot of fun, and a really great way to disseminate information is, as I'm sure you know.
Yeah, absolutely. So the
Yeah,
name of the podcast is Best Science Medicine Podcast.
yeah, BS without the BS. So best science without it, and so we try and not have any of that, that sort of the BS around it.
Yeah.
Because I don't know if you know this, there's a little bit of that in medicine.
Ah, I'm aware. I think that was like the main thing. Like it was so interesting. And I felt like my education in family medicine included some of the same tenets, which was great. And also, I noticed all the different ways that whether I was talking to family doctors like myself or specialists or whatever, but we're all talking about the evidence, but we're all like saying different things and are potentially influenced by different
Right.
industries,
Yeah,
factors. But
yeah,
yeah,
because there's evidence and then there's evidence and then there's evidence sort of thing, and it's not as
yes.
easy as it sounds. And there's no, the reason we do what we do, and I work with a great group called Peer that helps in the background develop some of this wonderful information with tools for practice, and we do some national guidelines that I hope that are simplified. Is that I don't think we should expect our primary care or any healthcare provider to be evidence experts.
Yeah.
They just don't have the time to do it. You need someone who does it on a regular basis. It's like saying, Joan, why don't you just do open heart surgery? Well, no, you find someone who you can respect and will do that for you, for your patients. And so, evidence appraisal is tricky. It's actually not heart surgery. So it's actually easier. I find it easier than that. But it's basically, how do you make a synopsis of the evidence? Because there's a bazillion papers out there, and so
Mhm.
how do you put it together and how do you think about it? And so our entire sort of job, I think, is to take the best available evidence and give it to healthcare providers in a way that they can understand it and use it. Because as I know I've heard on your podcast, is to say we need that information to make decisions, because just simply following guidelines is not the way to do, I don't think, the best way to practice medicine or healthcare in general. Because well, there's a lot of guidelines and they don't
Too
always say the
many.
same things. Whereas when you look at the evidence, you can present the evidence in different ways to make it say different things, but you can only, if you've got a clinical trial, the results are the results.
Yes.
And there may be problems with a trial or the study or whatever, but that you can only, there's only so many ways to spin statistics, and we try to not spin them at all and just say this is what it showed. And our big motto is we don't really care what the evidence shows, we just want you to know what it shows. And so
You're not
that's a skill.
influenced, right? And you don't
Well,
have an
we're yeah.
agenda. Or I
Yeah,
mean you're
what we do, we do have an agenda. We have that agenda,
right.
and,
Right.
we have an
Mhm.
agenda to make it as simple as possible. Not
Yeah.
because and we're not making it simple because everyone is stupid. We're
No.
making it simple because we're limited with time,
Yes.
right? As
Yeah.
you know, I mean, know much better than I do. It's a time thing. You can't do all of this, especially in primary care. So, and then, we saw over the years that the guidelines, we would read them and go, I don't think they looked at the evidence the way they're supposed to. They're getting a little bit better, but they just didn't. And and they were very saying, do this and do this and do this. And I don't think that's the way medicine works. So we're big fans of shared decision making when possible. It's not always possible, and not all, it's not always appropriate. So, there's a few scenarios, that we could chat about, but so that was the whole purpose, was to do that, and also have fun with it, because the if you're going to present, there's a great line. I have to make sure if I remember, but if if you don't know, if you think there's a difference between education and entertainment, you don't know much about either.
Oh, that's so good. And
Yes,
that
it's
is
from
so
Martian.
true.
Yeah, 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 yeah. So we try and make it fun as well, because come on, medicine is crazy, life is crazy.
Yeah, you have to find absurdity in it. And also, the only way to educate people is if they're paying attention to what you're saying. And
Yeah,
we pay attention to what is entertaining and engaging. So like
yeah,
those have to
yeah.
be
And
connected.
I've always thought, well, let's assume you didn't learn one thing. At least you enjoyed it.
Yeah. At least you had a
So
laugh, right?
yeah, you had a laugh, or yeah.
I did want to talk, and this might be like inside baseball only for those who are listening that are in primary care, but it's
Mhm,
almost as like a case study about just how we're a bit socialized to think about guidelines and evidence. And so
mhm,
I think using the cholesterol, the lipid stuff is a useful one.
mhm.
It's the one I still, so the way I was trained, like I'll kind of tell you my experience. So like I
Yeah,
definitely learned and saw from several of the people I was working with the like target based model where they were
sure,
following the guideline that says if their if their CVD risk is a certain number, then you have to get their LDL to a certain number
sure.
and you treat when it's a certain number. And it was all number based. And you studied that. And I think I was tested on it. I can't remember if it was actually in the test, but I at least studied it.
Well, yeah, and
Yeah.
that's one of the, we'll maybe get to talk about that. One of the things we always say as well, when it comes to licensing exams, don't listen to anything we have to say,
Yes.
because the licensing exams, almost by definition, because we're licensing thousands of people, have to be guideline based.
Standardized. Yeah.
Otherwise, there's no, because otherwise the answer would be, well, I discussed the benefits and harms with the patients, and we made a decision. That's the
Yeah.
answer to every question.
I know.
Oh,
That would be great
and
though, honestly.
I'm exaggerating a little bit, but you know
Yeah.
what I mean.
Oh, totally. Especially
Yeah,
when it
yeah,
comes to treatment, like testing less, but like treatment, maybe that's fine. Maybe that could be the new standard. But like it was really interesting then, like both a little bit from certain teachers within residency and then listening to your podcast and hearing you break down why maybe if you like when you examine the evidence, how making sure that LDL gets under 2, like is there evidence that that is actually equals the benefit,
right.
right? Versus if you're on a statin, for example, that affords a certain amount of risk reduction, period.
Yeah,
Like, and obviously if you have a higher risk to begin with, you're reducing it by a larger absolute amount, if you will,
yeah, yeah, that,
you
yeah.
know. Um, and so the idea of like set it and forget it, I don't know if you guys still use that term or if I just made that up, but like, where it's like we're saying,
There's a fire and forget.
ooh, love that. Exciting. So just like do it and then you're done.
Yeah,
The thing that's really interesting, so two places I found it interesting to talk about that. One is with medical learners. So you're kind of like, you're like, listen, when you're eventually in practice, you might want to follow this very simplified guideline where you don't have to keep testing
right. Yeah,
your cholesterol a million times. Um, but for the test, maybe you do have to. So there's tension there.
yeah,
Uh, and then also with colleagues who are very still following the other guideline and the sense of if there's judgment that you're not,
yeah.
and that like, oh, well, aren't you testing for LDL or,
So
like,
so it's peer pressure.
yeah. And like, it's
Yeah,
mostly imagined, but even like, say I
yeah,
had
I
a
agree.
locum or like, say you're co-practicing with someone and they're still using that guideline. Like there's sort of this tension of like,
Yeah,
what are we doing here?
Yeah.
you
Well,
know?
yeah, but you can't get away from that.
Yeah.
The issue is because there's roughly, and if we sort of focus on lipid guidelines, there's sort of, if you go look for them, there's six sort of major ones that I'm aware of sort of in the world. I'm sure there's other little ones, but there's
Yeah.
and half of them say measure cholesterol and half of them say don't. So what
There you
that
go.
tells you, and as you know, in Canada, there's the Canadian Cardiovascular Society, they say measure, and our guideline says don't bother.
Yeah.
So I don't know if you can say either is right.
Yes.
What I can say, and reason being, is how do you figure out what's right? Well, the really the best way, well, you can do it with a study. You could say, let's randomize people to get targets,
Yeah.
and then or randomize people to do to just give a medication and then see if there's any difference in outcome.
Yeah.
And so uh, but regardless of that, neither of those approaches takes into account uh, the patient's values and preferences,
Right.
right? So, but let's assume we do that. There are very, very few trials that have looked at getting to targets, and
Yeah.
there are almost none in cholesterol. Now, there was one, interestingly, just recently, and it was published about a year ago. And what they did is they randomized people to a sort of a treat to target LDL, or they just gave sort of higher doses of statins and said, just leave them alone. And what was really interesting, this is what they did. It was a non-inferiority trial, which means they're trying to show, are they the same?
Yeah.
And they did. They showed them that they were the
Right.
same outcomes. However, and the conclusion was they were non-inferior to each other. So work with me on this one for a second. Their conclusions were these findings provide additional evidence supporting the suitability of a treat target strategy.
But you just said they were the same.
I know.
It's not that it's like non-suitable.
No,
They're
no,
the same.
exactly. So let's just, I don't get that. And I know and that's the reason I read conclusions of a paper is not because I think I can get the answer to what it said. I really just read them for the amusement. Going, I wonder what they're going to say about it, and then you go
Yeah.
look at the things. So, but so let's assume it was a little bit better.
Mhm.
Let's assume, which I don't believe it is, going to a target. Let's assume it was. It's a lot more work.
Yes.
So, I would suggest there's no difference in outcome. So if there is no difference in outcome, why not make it simpler and not make people so obsessed by it? And
Yeah.
then in our guidelines, and we've done lots of podcasts on this and talked about this, the measurement error of
Yes.
cholesterol and all that sort of stuff makes you're just chasing a ghost. And
That
that's,
is, oh man.
yeah, so that's the problem that we run into. And I don't think a lot of researchers get that. And they also don't get how tricky it is to have to deal with all of the calls and discussions. And do you get your cholesterol every year or do you get it every 2 years? And our most recent guidelines say at most you repeat it every 5 years, and we'd prefer if it went to 10. And if you were asking me, I'd say I don't think you need to,
Yeah.
because I don't think you necessarily doing it. Just use medications that actually work.
Yes.
So that's and this concept around lipids that we're talking about applies to everything.
Yes.
One of our lines is we don't care how it works, we just care if it works. And
Yeah.
so our entire thing, I can't remember the last time I don't care if a drug lowers cholesterol. I don't care if a drug lowers glucose. I don't care how antidepressants work. I just care if they work,
Yeah.
because we screwed up on a whole bunch of mechanisms. You're far too young to remember when it used to be, if we saw a patient put on a beta blocker and they were in heart failure, we would phone up the doctor and say, you need to stop this because you're probably killing your patient. Yeah,
Oh,
beta blockers were contraindicated in heart failure.
that's no longer the case.
They're now drugs of choice.
Yes, they're on the list.
Yeah, so yeah, and with other drug,
Yeah.
but I have a mechanism for both of those things.
There was like the theoretical argument for why it was dangerous.
And now there's a theoretical argument.
This is what
But
I'm
and it's
saying.
not theoretical.
Oh,
They
right.
both had some
Like,
evidence, and now
right.
we have, yeah. And there is probably some truth a little bit to both of those. If you
Mm,
use 47 pounds of a beta blocker, you
sure.
might get into trouble. When your heart beats once a minute, that might be a problem, right?
Not compatible with,
Yeah, not
yeah.
compatible. Not compatible with a long life,
Yeah.
and you know, so it's that sort of a. So again, it's all about uh, does it work? And for many years, early in my career, I was taught by lots of really smart people, good people, nice people. This is not an industry thing. It's not a conspiracy.
Mhm.
It's just the way society works and education works. I was taught to do some things in healthcare, and then I was doing them, for lack of a better word, religiously, as we all do things religiously. And one day I didn't have a lot of experience, and this was way before the term evidence-based medicine or healthcare was even a thing. And I remember looking at a study that apparently supported what I was doing, and I
Mm,
read it, and I wasn't great at it. I read it and went, that study doesn't show that. I mean, a monkey could look at that study and go, I don't think that showed it. And I thought, well, there
mm.
must be something better. And that was the best one. So I realized that I had been taught around an area where the evidence was exceedingly sketchy. And I thought, well, this is so powerfully ingrained in what I do. Are there other things?
Mm.
And then as soon as you start to open up, undo that or peel that onion,
Yeah.
it's incredibly, things don't work nearly as well as we think. There are a few things. General anesthesia works in almost
Yes.
everybody.
Yeah.
That's about it as far as drugs working in everybody. Now everything is less than that. And if you followed our podcast and the work that we do, or the risk calculators that we do, most people don't benefit from lowering cholesterol. Most people don't. Let me rephrase that. Most people don't benefit from giving medications that we think work by lowering cholesterol. And the
Right.
same with blood pressure and stuff. But as you know, it's the same, but it's the same thing when it comes to thresholds for blood pressure and glucose and all that sort of stuff. We keep pushing them lower and lower and lower until almost everybody, if you have blood pressure, it's too high.
Yes, exactly.
If you have any glucose in your body, you need to get rid of it. And
Yes. Mm,
it's we are, I think we've hurt lots and lots of people with
mm,
this. Have we benefited some? Yeah, I think
yeah.
I'm sure you know as well as I. The patient who comes in with an A1C and is of 13 and is peeing all the time and thirsty, we can
Yes.
help them because they're
Yes.
symptomatic.
Yeah.
But you can't make an asymptomatic patient feel better.
No.
So that's the almost everybody. Well, you tell me if again, you have more experience with this. There are very few people that you see nowadays that have symptoms associated with their blood pressure, cholesterol, or glucose.
Like there are some, but the vast majority, you're looking at the numbers and you're
Yeah,
showing them the graph.
yeah,
And I think a thing, so, and it comes from us, and now it also comes from patients. Like there's something about the certainty of a number. And
yeah,
it's like, here's your report card. And sometimes it actually says report card, and we don't even
yeah,
pick
yeah,
up on the like subconscious like shame conditioning baked into
yeah,
that.
yeah.
Where like you're gonna be mad at me. My A1C was 7.2. I've been bad. Or like the way
Oh, I
that
know. Yeah,
it's
yeah.
so brutal. It's like speaking of religion, it sort of is like this sense of also though, I will say like some patients again, it's helpful to think of it patient values because some patients they want me to check it. They want to check their goodness based on the numbers. I
Right.
found those conversations a bit trickier because it's like I'm honoring their values, but I'm aware that part of why they have this value so strong is
It's
because
your
of
fault.
this. Yeah,
Yeah, because you
exactly.
told them to do it in the first
Yeah.
place.
So I'm like, like whatever
Chill.
this number shows, like, so the classic one is cholesterol. They want to do really good on their lifestyle. which is a lot of tricky, problematic, can
Mhm,
be problematic language anyway. But like, say they do really good on their lifestyle according to them, according to their goals.
mhm.
They want to see that the number, that the
It's
cholesterol has
changing.
shifted, and it really doesn't. Like, even if they've made a
Yeah,
huge shift,
yeah.
A1C, I have seen it shift, but and
Oh,
it again, it
absolutely.
depends
Yeah,
on the
yeah. There's no doubt.
person.
Like A1C, you can see it,
Yeah.
and there are certain things you can do for blood pressure and things like that. But
Yes.
even then, it's still, it's tricky to pick up. But
Yes.
I'm sure you know this, but one of the ways to sell drugs is to sell a test,
Oh,
right?
yes.
So because I'm sure most of the people who are listening, we've used, maybe inappropriately, we've used aspirin for primary prevention, right?
Right.
But we don't go, oh, you know what? We need to check your aspirin level.
No.
No, we don't do that. We don't need to check your platelets to see if they're less sticky.
We don't have this.
One could probably do that,
Yeah.
but we don't. And
Mhm.
and the issue around all of this is not that it's the people who say, well, you got to be measuring all this stuff because it's so important and it's this, that we are not. I don't think anyone's arguing that there is definitely, the higher your blood pressure, the greater your risk of heart attacks and strokes. The higher your cholesterol, in most cases,
Yeah.
there are times when it isn't, and the higher your glucose. So no one is saying that it's not necessarily even a causative thing.
Yeah.
What we're saying is, though, does lowering it have a benefit?
Yeah.
Because I'll give you a great example. I'm sure you know the drug atenolol.
Mhm.
So for the people who don't know, that's a beta blocker that lowers blood pressure. And it was, I think, one of the top drugs prescribed, period, in the world about 25 years ago. It was used a lot. And it does work for high blood pressure. The problem is there are 4 large, well-done randomized controlled trials showing when you give that medication to people and it lowers blood pressure, it does nothing to cardiovascular outcomes. So that makes your life very difficult.
There's a gap there that we're
Yeah,
missing.
and that doesn't mean every beta blocker may not be useful. But what it tells me is there are way too many examples of drugs that change surrogate markers that don't change outcomes. And in
Yeah.
fact, uh, between sort of 20 uh, what was it? I think 2005 and 2015, so it's about a 7 or 8 year period. There were, I think, 20 large randomized controlled trials done in a row that looked at drugs that lower blood pressure, cholesterol, and glucose, and combinations. And I didn't cherry pick these. I just followed all the large trials as they were coming out. None of them showed a benefit. 20 in a row. And I went, that's just way too many
Yeah.
that that we should therefore be beholden to a level,
Yeah.
because we can make too many mistakes. I mean, we've only just in the last 6 or 7 years actually have medications in for type 2 diabetes that actually reduce risk a bit.
Yeah.
Like I'm the evidence is pretty clear that sulfonylureas that we've used for a long time and insulin do nothing but cause hypoglycemia and weight gain. They actually don't improve outcomes. And I think it's really tricky. And here's sort of the proof of this, of why I'm saying this sort of thing. Back in we had we for many years we had only really one trial. It was called the UKPDS, that looked at whether or not giving a medication for glucose like metformin or whatever had a benefit.
Mhm.
And we kept getting burned by all of these medications, and the FDA at some point said, you know what, guys, people who are making these medications, you now have to do studies that show that your drug does something other than lower glucose, because you get drugs on the market just by showing they lower glucose and by showing they blood pressure. You don't have to show necessarily that they
Mm.
reduce outcomes. So we were talking about a non-inferiority trial. So they said you need to do non-inferiority trials. And normally when we do non-inferiority trials, we do things like a non-inferiority trial of uh, I don't know, ibuprofen versus acetaminophen. We want to see if they're the same, or
Yeah.
they're not different. That they do something, whatever it is, So we do non-inferiority trials using when we're comparing two active agents. The FDA required the companies, and there was many companies that were producing these medications because there's so many people who have diabetes. And I don't even like the term diabetes. I think we should stop using that term. That's a whole other conversation.
I'm intrigued.
But so they mandated you have to do non-inferiority trials against placebo. So you have to prove you're not worse than placebo, because the problem was
No.
many of these drugs were causing harm.
Yeah.
So the standard
Oh,
was these trials were non-inferiority trials
yeah.
to show that they are no worse than placebo. Now, some of them showed superiority, which
Mhm.
is good,
That's great. We love that.
which is great.
Yeah.
I mean, we're still talking about 2% of people benefiting over 5 years.
Sure.
But
Yeah.
so I don't, it's not great, but
Right.
that's what we're talking about. But all of those trials, when you're looking at the SGLT2s and the GLPs and blah, 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 those are all coming from non-inferiority evidence from non-inferiority trials.
Mhm.
And those were done because of the problem.
Mm.
I think I find it it's fascinating as uh, a bystander who doesn't really I don't really care. I do
Mhm.
passionately care, but I don't really care, if that makes any sense.
Yeah, I get
It's
it.
a fascinating thing to just watch as an outsider, even though I'm inside it.
Yeah.
And
Mhm.
almost you're the same sort of person. You're not on the inside on this. You're on the outside,
Yeah.
being influenced by all of this sort of stuff. And I'm sure you've had the same experience in your practice where people have told you things, and they're good people, they're smart people, and you trust them, and you do what a lot of what you do is because you were told and saw what other people did.
Yes.
A great example is, why would you ever, why do you prescribe 10 days of antibiotics? Because 9 is stupid.
9 doesn't feel like you're doing enough.
You're just not doing enough.
Feels
But then if you were going
dangerous.
to do 7, then 9 is way too much.
Yes. It's
You
like
know,
anchor
yeah,
bias or something.
yeah.
I'm like,
I
no.
mean, because that's another sort of belief things where, you have to take the antibiotics till they're all gone because there's a label on it. Well, that's a
Mhm.
myth. That's not, there's almost no truth to that. In fact, it may be the opposite.
Right.
So and Mike and I published an article on this in the BMJ about that issue, and a lot. By the way, we don't invent this stuff. A lot of other people, we stand on the shoulders of giants. A lot of people have thought about all this stuff before, and with most like antibiotic prescriptions, it's why do we do it the way we do it? Because that's the way we were taught to do it. And there's a mechanism. Well, if you don't treat it till it's take the antibiotic till it's all gone, you'll get, resistance and then a super infection, then you die. But
Mhm.
you can make the similar argument that the longer you're on an antibiotic, the greater chance of resistance, and then you'll get a super infection, then you die. So mechanisms are stupid, or
Yeah.
or very confusing.
Yeah.
So we now know that so many uh, infections that we can treat from much shorter periods of time. But even if we know on average that antibiotics, we only need, let's say, it used to be that you had to treat pyelonephritis for 2 weeks. Now we know it's 1 week
Mhm.
because it was a study that was done, showing 1 week was just as good as 2 weeks. And we have, from many, many primary care infections, evidence that shows that we can do that. But that never tells, that's all the average. So I like to try to add in the personalized, well, what if they got better really quickly?
Yes.
Then you can just stop it. So, for most things, not endocarditis, not prostatitis, but things like that, those,
Yeah.
those are, we don't really know how long to treat those because they're tricky to treat at the best of times. But all the rest of the
Mhm.
other stuff that you guys are doing, I just simply tell people, and this is, people go crazy with when you tell them this, right? They go,
Yes.
you have got, how dare you tell people this? Or are you the like worst healthcare provider ever?
Yes.
Right? Yeah.
Right.
They look at you like you're an idiot. And it's such a powerful belief, right?
That like we keep saying, like the religious doctrine, if you will, like the
Yeah.
dogma of it. I actually think, because like it was really interesting. I was speaking to someone else who'd also listened to your podcast, And he said that like he just recently graduated, and then when he listened to your podcast, he felt like an identity crisis. And I didn't feel a full identity crisis, but I definitely felt very similar to when I felt when I like deconstructed a certain actual religion I was a part of. But like it
Mhm.
was really interesting how destabilizing it is. How it can be like I like people listening might be going, "What?" And like actually maybe having an emotional experience
Yeah, well, it's
depending
a
on
cog.
how in
Yeah.
like it, so tell me like what's so first of all, I guess the reactions that you get, like what's your insight into this phenomenon we have where we're not actually interested in what the evidence shows per se. Something else is driving how we're wanting to practice and why targets and guidelines maybe feel
Well,
soothing or
they're
something.
comfortable in it, and you have the impression you're doing something. One
Yeah.
thing. Now, but that, I'm not against targets. I'm against targets if we don't have evidence for the target.
Yes. Right.
So there may be, but there's very few things that really targeting anything is really good because, it would be like saying let's make sure everyone drinks to a target amount of alcohol.
Yeah.
I mean, I can't speak. I'll speak for you, but maybe I speaking inappropriately. You figured out the right dose of alcohol for you,
Yeah.
and it wasn't in a guideline.
No, it was
And
the impact on my body.
yeah, and you went, well, a night, one or two drinks was fine.
Mhm.
uh, Eight was ridiculous, and I shouldn't have done that.
Yeah.
And even, and I'm not talking about that. I'm not talking about anything to do with the health aspects of
Right.
alcohol, just the intoxication
Yeah.
sort of thing. And so one of the most important things is no matter what guidelines you have, we're all genetic mongrels. We're all
Mm.
different, so there's no way you can predict it. So one of the biggest messages that we tell people is using lower doses,
Mhm.
because you cannot predict how a person is going to respond. I'm sure people, you give medications to people and they tolerate it fine, and then there's people who just don't tolerate anything.
Yes.
They're not in the guidelines. So your job, and you're right. When people come and listen to us for the first time, they go, oh my God, I'm what am I doing?
Yes.
And
Destabilizing.
yeah, it is this, because
Mhm.
there's this cognitive dissonance going, well, what have I been doing? Now, we think, and I have enough experience of talking to people that this empowers you
Yes.
if you allow it to not control you.
Yes.
Knowing a reasonable idea of what the evidence shows is absolutely empowering.
Mhm.
It does require more. It doesn't necessarily require more work. It requires more talking and
Yes.
explaining. But when people say, like if you read some of the hypertension guidelines now, some of them say if your blood pressure is 140, or sometimes it's 150, depending on, again, what guideline you read. I've always said, if just tell me how you practice, I'll find your guideline that supports you. But they're saying, at 140 or 150, treat immediately. And I'm going, that's really, this is not.
140 treat immediately.
Yeah, this is not an
Even
urgent. This is not an urgent thing.
yeah.
If it's barely urgent if your blood pressure is 210 over 120,
Yeah.
if you have no symptoms.
Yes. Yeah.
So it's this, and I don't know. A lot of people will say that the guidelines are, influenced by industry, which they definitely are.
Yeah.
But I don't think there's all these evil people on the guidelines, because
Yeah.
I know lots of them, and I
Yeah.
know they're not horrible people trying to do damage to people.
Yeah.
They have a belief about it. But I think one of the things that we've done, and if you looked at, when you read our guidelines, they're all called simplified. And in
Yes.
fact, even before any of this, when I started writing articles, we had the simplified paper version of a risk calculator,
Mm.
because I realized that um, when you delve into the information, you can make it simple.
Mhm.
Because it's not that complicated.
Yeah.
And so, but to do that, I don't think I should just tell you what to do.
Yes.
I need to give you the tools to be able to do that yourself. And hopefully I mean, generally people trust that we have done a decent job of looking at the evidence, and we're not just sort of making stuff up. And we're
Right.
not, because and also here's another thing that I think about is I've talked to so many healthcare providers and often new learners. They're they you know they call I cannot get my people to stay on warfarin. I can't get them to be on a statin, and I kind of go, that's not your job.
Yeah. Why do we feel like we have to put things on people or else we're failing? Like that's a
Yeah,
big
yeah,
problem.
yeah. There is not a tool that can measure my how much I care about whether or not a
Mm,
person takes a statin. There is not a tool that
yes.
can measure that small of a thing.
That's great.
Here's what I do care about. I care that I've talked to you about it, and that it makes you have a decent idea of the benefits and harms. And if you want to take it, I will support you.
Yeah.
And then and often, people like yourself will ask, well, would you take a statin? I go, well, if I'd had a heart attack, uh,
Yeah.
I think 5% benefit, it's pretty well tolerated. If it didn't annoy me and it wasn't that expensive, I'd probably take it. Would I forget a whole bunch of times? Of course, I'm going to be the world's worst adherent person.
Yeah.
Uh, um, so it's that approach, and I think it's a more honest way, because I don't think guidelines are not written for Joan.
Yes.
They are not. Now they may be at some point, like when you're the ultimate leader of the world.
No, thank
Yeah.
you.
And like I said, even back to the doses, the doses of, but there's a whole reason why when a new medication comes on the market, the doses are too high.
Mhm.
For those of you who, for the younger people, I'm sure most of you have heard of a drug called hydrochlorothiazide. When it first came on the market, it was you start at 50 and go to 200.
Oh my gosh. I
Yeah.
have never. Yeah.
When Yeah, we don't quite use that much anymore.
No.
How about this as a thing? When I started practice in 1982, I was doing a residency at Lionsgate Hospital, and ACE inhibitors had just come out.
Mm.
Uh, when we were starting ACE inhibitors, you had to hospitalize every patient when you started them.
What?
I know, it's crazy, right? But the reason
Why?
was
Yeah.
we were using we were using doses that would be the equivalent of Ramipril 80.
Oh. Okay.
Yeah,
And that's like how where you would start.
yeah, and
Okay.
people collapsed.
Yeah. Like that fainted slash their kidneys stopped working or like both.
Yeah, well, yeah, and they don't just stop, but
Right.
they usually they use. Here's a medical tip:
Yeah.
if you have no blood pressure, your kidneys don't work.
Right. Yes. It
It's
wasn't
it's.
like
I know I'm not supposed to
yeah.
talk about a mechanism, but there you go.
That's a good one though. I can follow that. That's
I'm
like
sure
a
you can follow that one. Yeah,
flow chart, very easy for
yeah.
me.
Although there's one of my good friends and colleagues, Bob Ragnar, who we worked together and taught together for years. His line was he was one of the the hypertension experts that you'd send people to who had really difficult to control high blood pressure, and he saw a lot of this, and he'd always tell his patients, look, high blood pressure is better than no blood pressure at all. So let's start
Okay.
from there. Yeah.
Yeah.
And so yeah, so that's the premise. And uh, almost here's another example with inhaled corticosteroids for asthma. When they
Mhm.
first were used, they were the amount that we were giving, with the amount that you would absorb of that was the equivalent of giving people 5 to 10 milligrams of prednisone a day.
Oh my gosh.
Yeah, so there are hundreds of examples of medications we've used with much higher doses when we know that almost all the effect comes from much lower doses. So all of the
Mhm.
ACE inhibitors, if you're looking at their effect on blood pressure, you get almost all the effect from the lowest dose you can possibly use. You never get more of an effect from doubling a dose,
Okay.
or
I don't
very
think
little. Yeah, I
I've
mean, you get a bit
yes,
more.
like that is so true to my practice. And I think I must have missed that podcast, but like that is so true, like anecdotally over time.
Yeah.
you're trying, and it just doesn't do anything.
No.
So, okay, that's very
Now,
validating.
so how do you figure out the right dose for someone? Well, the right dose for someone has nothing to do with anything but how sick they are. If they're really sick, use big doses,
Mm.
right? Because you don't know. You know,
You're
if they're
like, take everything
yeah,
and
yeah,
give it,
yeah,
yeah,
relatively speaking.
right.
Because here's a great example. I remember, and I've told this story lots of times on the podcast, and lots of people that you're eventually getting sick of it. But I did infectious disease at St. Paul's for about 17 years. But before that, when I was doing my when I was training in South Carolina, I was doing an ID rotation, and I was working with some of the top ID guys in the Eastern United States at the time. And we were one of the patients we were seeing. They had a patient who had osteomyelitis of the jaw, and it was caused by Pseudomonas.
Mm.
And that's not something you want. But at that time, we would use a drug called ceftazidime, which is a third generation cephalosporin, which has activity against Pseudomonas, blah 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 blah. And
Mhm.
so one of the lead main guys in the Eastern United States was the person who was we call him the man of the month. I don't think that's the way we should be saying it anymore, but it was the main guy that was responsible for everyone.
Mhm.
And I just said, I was sort of young and stupid, and now I'm old and stupid. But I asked him, said, how do you figure out the right dose of an antibiotic? Because I couldn't find anything on it. And
Mhm.
he had a bit of a southern accent, and he looked me in his eye. He says, let me tell you, 1 gram feels good, but 2 grams feels real good.
That's great.
And that is how we dose antibiotics.
Mm.
There is
It feels
no
good.
magical thing that we do. If they're really big and really sick, you give lots. And not only do you give lots, you might give 3 of them.
Yeah, just,
Yeah. Whereas if you're going, I think you have a virus,
yeah.
you probably don't do that.
Mhm.
And that's your skill.
Mm.
That's
Mhm.
your ability. And are you going to sometimes make mistakes? Yeah.
Yeah.
But you are making a mistake every time you prescribe a drug. You are always causing harm,
Mm.
cost,
Yeah.
inconvenience, and side effects.
Yeah.
So everybody's harmed. And every time you make the diagnosis of diabetes, you are harming
Yes.
people,
Yeah. That
because
one.
now everyone's going to go home and, guess what I found out today? I
Yes.
have diabetes.
It's
And then it sets
devastating
an
for people. Oh
entire
my gosh. Yes.
the family gets involved. There's
Yes.
phone calls, and dad's got, it's
Yes.
versus what you should be saying is, uh, you know, based on your A1C and or your blood pressures and stuff like that, we think your risk is now this. Because it
Hmm.
doesn't all of a sudden jump up when you get to these thresholds.
But you have a label now.
Well, I know
Different.
you'd love to do labeling. Yeah.
A new toolbar appears in my EMR.
Yeah. But I
Yeah.
think we do a lot of harm with,
Yeah.
you have diabetes. Because
Yes.
I think what we should be saying is your risk of a cardiovascular event is about this. And I realize that our calculators, or any of the calculators, they're not great at doing this.
Right.
They are better than you. Who,
Right.
if I give you 7 different things, blood pressure, cholesterol, age, and you're just basically pulling
Shrug.
the number out of your rear
Yeah.
end.
Mhm.
So we're giving a little bit of clarity to it.
Mhm.
We're trying to make it a bit more, and realizing that most of these overestimate risk. Most of these calculators overestimate risk at the best times.
Mhm.
So, but we just want you to be able to show people it's not about, because this just so I'm gonna you tell me if you think this is shared decision making.
Yes.
Joan, you have the silent killer. Would you like it treated?
No, I would offer that
That
as not shared
yeah,
decision making.
but it
That's
is.
terrifying.
Well, but I've given you the decision. I've asked you. I want you to make the decision.
Sure.
So
Yeah.
that's the problem is it's not really that you're not in that you're not really informed.
Yeah. You're just nervous, right? I did want to ask, I don't,
Yeah.
this is the peer guidelines Did you do anything with diabetes? Do you have a diabetes
We
specific
are
guideline?
working on our diabetes guide as we speak.
Okay,
It
I look
is,
forward to that.
it is gonna be it's gonna be tricky.
I think there'll be some branches and some organizations who may
There will
be
be,
upset.
I hope there will be lots of happy people
Yes.
and there will be a lot of unhappy people.
Because the thing that I love about the one that I pull from and like share a lot is the lipid
Mhm.
one. And it brings me a sense of relief. So first of all, it's because it's simpler. I think it is valuable when there are less things to do, because in medicine there are too many things to do.
Right.
So if now I feel like I'm doing a great job reflecting the evidence and offering my patients solid evidence-based approach to medicine,
Mhm.
and it's way less tests for them, way less
Yeah.
titrating things, I'm going to sign up for that category
Yeah.
every time.
Yeah.
Thank you
Well,
very
there's a
much.
big thing now, it's called, you've heard the term numbers needed to treat. Now we're talking about time needed to treat.
Oh,
And
that's so good.
yeah, because it's time, this is a lot of time. I mean,
Yes.
I can't tell you how charming you are, but but I don't need to see you every day.
No, I love
I,
not seeing my patients.
yeah,
And then they should love not seeing me.
yeah, because no one goes, what's going to be fun today? Going to the
Mm,
doctor.
no.
It's a little bit better now because of COVID, because now I don't have to come and see you as often.
Yes.
I can just talk to you or whatever, which is, I think, a good thing.
Yes.
But so it's so and I don't know, it'll be interesting. I don't know what our guidelines yet are going to say with
Mhm.
type 2 diabetes, but I mean, how do we figure this one out when, we've got this pre-diabetes thing.
Ugh.
I
Yes.
know. Yeah, basically we have everything. We got, pre-diabetes,
But then there's
pre-hypertension.
even another category lower on Life Labs, at least. So it's like pre-diabetes. And
Yeah.
then there's at risk of diabetes, which people also get very anxious about, which is like A1C, like, I don't know,
But is it at
5.5 to
risk? But
6. It says
yeah, but is
at
it a,
risk.
oh, it's not, I haven't seen it. Is it, so it's not that they're at risk for pre-diabetes.
Like, I know it says the words at risk.
Yeah, but
I don't remember.
it's hard to, it'd be interesting to know what that even means.
Well, who can say? No citations. They just put it on this thing, and now
Oh yeah, yeah,
patients can
yeah,
look it up
yeah, yeah.
themselves, and patients are like, I'm at risk. And you're like, I mean,
Yeah, chill. Yeah.
ah.
But the problem is it's so easy. It takes 1 second to read that, and it takes you
Yeah.
30 minutes to
Yes.
deprogram that.
Yes. If that, they're still quite skeptical,
And they're
because
still
the
going to be
health
afraid of it,
anxiety
right?
is the health anxiety and the shame about health is like so high. And it's just like, if we can minimize the harm we do around that,
Yeah.
I'm interested in that.
Yeah. But
Yeah.
because and it's a great, if you were, if we gave you the task of writing a guideline, tell me how you would deal with this. So what range do you use for prediabetes? Between 6 and 6.5?
4. Yeah.
Well, 6.4 usually.
6.5, I think, is officially
Yeah.
diabetes. I
Yeah.
think. Yeah.
So I just want to make sure so we're talking about the same numbers.
Mhm.
So let's say prediabetes is between 6 and 6.5
Yeah.
A1C.
Mhm.
So if you measure an A1C and it comes back at 6.2
Mhm.
or 6.3, we know the plus minus on that measurement and not is about plus minus 0.5. So here's what you can confidently tell someone
Yeah.
if their A1C is 6.2 or 6.3. You're either normal, or you have prediabetes, or you have diabetes.
Yep.
So that is an uh, inescapable fact because
Yeah.
of the measurement variety. And it's not the lab that's the problem.
It's biological, right?
It's
Like,
the biologic variation.
mhm.
So if that is true, and I'm suggesting it is, I wrote an article with one of our lab guys here that got published in the BMJ 2 or 3 years ago, where we talked about this big problem of measurement variation.
Mhm.
If that is in fact true, which I believe it is, and I don't think you can change it, how can you use at threshold of pre-diet? You can't.
Meaningless. Yeah.
It's kind of meaningless,
Yeah.
but it doesn't make it. But it's so that's the debate that we get into
Mhm.
because it felt so right to begin with.
Yep.
And I don't know what you do. There is no solution to that. One of the arguments, there is no we can't fix this, but you need to know about it.
Me as a clinician, and me as a
And
patient.
patients.
Yeah.
And the reason that
Yeah.
it was quite funny. It was um, about 5 years ago, 6 years ago, I was invited by a lab group in the States, pediatric lab group, actually. I think pediatric lab people. It was a big organization. They said, we'd love you to come and do a keynote for us. And I said, yeah, I'd love to. I love doing these things. They're kind of fun and they do that. And and I said, what would you like me to talk about? And they said, anything you want. And I said, are you sure?
Yay. You
Yeah.
give a pitch.
Yeah. So can I talk about how you should be doing things differently? And so this whole measurement variation thing, I said, why don't you tell people about this? They all
Yes.
know about it.
But I
And
never was taught about it. The first time I heard about this was on your podcast. Like that,
yeah.
and I made a little spreadsheet of the variability so I could like kind of know
Oh yeah.
like
You're now my favorite podcast listener.
I gotta show you the spreadsheet, and hopefully it's still probably not accurate because I made it a
Yeah.
while ago. But even just knowing like things like TSA, like some things have such a wide variance, and then I see myself, and then also whoever else around me, and we're like titrating doses based on not the way I usually say
Yeah.
it is not statistically meaningful. Like it hasn't changed enough that we know it's a real change. Like I'm trying to explain this
Exactly.
to patients,
Yeah.
and they're like, "But the number's higher," and you're like, like it's yeah.
Yeah.
I don't have any
Uh,
solutions, but it's hard.
no, but and it's the same with, and the main reason why, or one of the main uh reasons why we're saying don't bother measuring cholesterol is the same reason, is
Yes.
when you if you give a statin, you'll see about a 30% reduction in cholesterol. You can probably you will pick that up with lab values.
Yeah. Yeah.
If you now if you go from 10 milligrams of, say, atorvastatin to 80,
Mhm.
you now get another 10% lowering of cholesterol. So it was 30% with 10.
Yeah.
You octuple the dose,
Yeah.
you get another 10%. That 10% is, you cannot pick that up with in individuals because of the measurement variation. You need to
Mhm.
see at least a 20% change to be able to be confident that it's actually changed.
But James, the new
I know.
guidelines say it's the LDL, it's not just under 2, it's got to be under 1.8. And this is
Yeah,
big news. This is big news. I was
I know.
listening to the cardiologist and I was like, I actually raised my hand. I'm like, are you concerned about the fact that like the variability of this test wouldn't
Yeah.
even account for the difference between 2 and 1.8? And I kind of forget what his answer was, but it was not convincing that he cared. And I was like, what?
Yeah. Yeah. And so just so you know, not every uh expert
Yeah.
knows all of these things.
No. Why
Because
don't we get
I'll
taught
give you,
them?
yeah, I'll give you a great example. I'm not invited back anymore because I got in a little bit of trouble one time. Not trouble with, there was a cardiologist who took great offense to me saying, you know what, you don't need to measure C-reactive protein or high sensitive HS, yeah,
Yes.
and that was really annoyed them. So anyway, I used to get invited to a cardiology convention in Toronto, and to do a debate. And debates are fun
Fun.
if the two personalities are fun.
Yeah.
When one of the personalities is not fun, it's never fun.
Okay. It's just
Yeah,
tense. It's awkward.
because they then they get kind of, they don't like being, you know uh, I'll just leave it at that. So, but I remember the very first one I did, it was, should we be using, I think was, should we be using statins in people for primary prevention? And this is probably 15 years ago. And I said, my argument was, exactly what I said just recently, is, well, here's the benefit. There's, if you want to take it, great, don't. And if you don't.
Yeah.
Whereas, almost all guidelines say treat or don't treat. And
Yeah.
so, and I was debating one of the cardiologist guys there, and very nice guy, and we had fun, and we just poked fun at each other about what we do and that sort of stuff, and I think it was well received. And I remember coming back the next year, I had to doing another debate on something, and I remember what it was, and I got into the elevator at the thing, and we're going up the elevator, and the guy said, hi, nice to see you again. And I went, oh yeah, you're the guy we just debated. He says, that thing you were talking about with numbers and talking to patients and the absolute, that's really useful.
Oh, yeah, it is useful.
Yeah, you and
Yeah.
if there's and I, I'm going to use you as an N of one. I
Mhm.
would say, there's lots of healthcare providers that I've spoken to who, you get to age 35 and 40 and you're kind of fed up with a lot of things.
Yeah.
And then I'm not saying this is going to be for everybody, but I have had enough anecdotal experience that when people embrace some of the things that you and I are talking about, medicine becomes more, I don't, I've used the word fun and people take offense to that, but it becomes more rewarding.
Yeah. Oh, yeah.
Because then you're not just a monkey going, do this, do this, do this, and do this. Now
Yeah.
there are, I'm not against all guidelines. In fact, we should have policies. Like the example that I've used in all the time is there needs to be a policy that when we're doing surgery, you count up how many instruments you have, and
Mhm.
then after surgery, you count them again.
That's a really good one. I like that as
Yeah.
a
So that
standard. Love
yeah,
that. Yeah.
I am all for that guideline.
Yeah.
You know,
That could be a rule even. I wouldn't mind.
yeah, I think that's a policy. That's we're
Yeah.
gonna, but it still comes under the, and by the way, there's no randomized controlled trials of that.
No, right? Yeah, that's so
It's just freaking
interesting.
common sense.
Yes. Yeah. Huh.
But even though it was common sense, we still had to put it in writing because it
Yeah.
wasn't done and we'd lose it, that sort of stuff. So
Yeah.
it's that uh, we absolutely need guidelines,
Yeah.
but what we don't want is the guidelines that we have right now.
Mm-hmm. Mm-hmm.
If that sort of makes any, because
Mm-hmm.
guidelines would be brilliant, I think, if they were written by the people who use them.
And say like it could even be something so like here's some language I use about it. Here's some tools that help explain the knowledge,
Yeah,
right? Here's the absolute benefit, potential benefits,
yeah,
like and like here's some practical ways that fit into your 10 to 15-minute appointment. I would like gobble up those guys. That's like basically what the peer one helps me. It's like here's the tool that I use all the
yeah,
time, like the online calculator. I love just sending it to people, so I'm justified in not ordering like the apo lipoprotein, whatever, like that the
yeah,
extra test. I'm like, look, you can use this if you want. Isn't it fun? So like the
yeah,
pragmatic approach, right?
yeah, yeah, exactly. So uh, you have become the person we wanted you to become.
Yeah. Hey, well, thanks.
I don't know if it's better, and no,
Mhm.
but this is a really important thing to think through though, because if if what I'm telling you, if you are doing what you are doing, let's assume
Mhm.
statins really do work. I
Yeah.
think they do. I think you'd have a hard debate to say they don't reduce cardiovascular risk.
Yeah.
Uh, if there were a lot of people who would not take it for a 1 or 2% absolute benefit,
Mhm.
if we were to do a randomized controlled trial of shared decision making, the trial
Mm.
would show increased risk for heart disease from shared decision making.
Because less than 100% of people
Would
would
take it.
end up taking it. Yeah. We don't know
So
which ones benefit or whatever, like however you think
yeah,
about that. Yeah.
so that is why we don't. I I don't. I think you can come up with reasons to do some shared decision making trials, but
Mm.
shared decision making is not the outcome of shared decision making is not better health.
Mm.
It's the right thing to do.
Yeah, first of all, it's more realistic because even if we're the fact that we think actually that we have a say in our patient's decision making is interesting. If you know what I mean? Like if we are say we do the full authoritarian approach and we're
Mhm.
like take it, take it, take it. That's not 100% that they're all
Oh,
taking it
you're
anyway.
not,
You know what I'm saying?
yeah,
Like
yeah, you're not even close. So yeah,
yes, like there's still like the patient gets to consent and decide what the heck they're doing. It's more just like how do we want to bridge that gap and be supportive and foster like a human to human relationship with our patient that I mean, I'd like to think that that actually has some therapeutic benefit that would be hard to measure,
absolutely, yeah,
but
yeah,
would be different than how many of them have heart attacks.
yeah, yeah,
It'd be different.
and yeah. So I think it's okay to make decisions that may not necessarily make you live longer.
Stats. Yeah,
I
there's
mean,
other
it's
meaningful
we don't
things.
want people to do really ridiculous things, but people do ridiculous things.
we just aren't in
I
control of
mean,
them, actually.
people go climbing. I mean, if you
Yeah.
didn't,
People drive cars.
yeah, exactly. So
Yeah.
how do you, put that round peg into a square hole? I mean, it's very tricky, right?
Hmm.
So but I think we, you know, if you really want to improve adherence, tell them you don't care if they take it.
Yeah. Let
Just go to
them
say
understand
it's up
it's
to
their
you.
choice. It's
Yeah,
your choice.
yeah.
Absolutely.
Because
Because
I
they
say I don't
recognize.
care if you take it. I do want to know if you don't.
Yes.
Because
Like, so I stopped.
I won't get mad at you. I will get
Yes.
mad at you if you lie to me.
Yeah. And that's
That will
fair.
be frustrating because then we're just being ridiculous.
Yeah. Then
But if
what are
you
you doing?
say, I mean, I'm sure you've seen patients like this, they're on 20 medications. I go, I have no idea how you can possibly take them.
Yeah.
I have no, I could not do that.
Yeah. That's a lot of pills.
Yeah, but I have had the case, I said, I remember just talking to, there was this lovely 80-year-old person, and I said, you know, uh, I'm sure you must on occasion miss medication. I do not miss ever mit. I said I do it, and they
Yeah.
are, religious about it.
Hmm.
And I went, oh, no, no, I wasn't trying to suggest. I'm just saying I couldn't do that.
Yeah.
you know. And
Oh,
but you
wow.
know why? But they are doing it under the false belief that you have to take it. Sorry, one, that you have to take it, and two, that it's actually gonna that they're gonna benefit from it. Like,
Yeah.
the numbers are fairly clear about, if you ask a person, how many people do you think benefit from treating high blood pressure? The mean sort of response is 70%.
Hmm.
Well, the absolute number is like 3
That's a
over,
hard
over
number to
5 or 10 years.
Yeah. That's hard to swallow.
So they're not
You
even
know,
like, I wouldn't have a job if, when you said the benefit, if the benefit was 60 and you said it was 65, I don't
fine.
care.
Yeah. Who
Yeah.
cares? Yeah. Mhm.
But it's, we're not even close.
Yeah. Not even close. Remember how I was like, I wonder if we'll talk for an hour, and then we
Yeah,
like
yeah,
definitely have. I
yeah,
think
yeah.
like we could definitely talk for another hour,
Sure. Well,
and
yeah,
we'll just have to do it another time.
I think
But I
that'd
want
be
to be
good.
respectful of your time. Thank you
That's
so
very kind of you.
much.
Yeah.
It's such a pleasure to talk to you, and you are very entertaining, as I knew from your podcast already,
Yeah.
but it's very fun to chat with you as well. Where can people find I'm going to put links in. So I'm going to put in
Yeah.
the calculator for sure, and like the peer guidelines,
Yeah.
and then
There's a peer website, and then there's
yeah.
uh, we've got the website, for the podcast. If you go
Yes.
to therapeutics-education.org, and
Hmm.
if your listeners are interested, we do an annual course every year in Vancouver.
Hmm.
We do it. It's now, live and streaming,
Hmm.
and that's coming up. I'm gonna get the dates for that. Make sure I get them right. That is coming up. Uh, May 24th and 25th. We'd love to have you attend that if you can. And we do all of this. We have people who, there's lots of people who think like we do.
Yeah.
There's not much money in it. And I don't mean money. This is, almost all of us that do this, I'm blessed that I got an academic job. It allows me to
Hmm.
do this stuff. And that's what most of the people, about that we work with peer, a lot of them are academics who are just doing this because they're passionate about it.
Mm.
So
Hmm.
there's that, and I have a YouTube channel where I do some fun music videos. I don't know if you've seen any of those.
No, that's
Yeah,
fun.
I take popular music and re-lyric and re-perform the songs.
Yeah.
And yeah, this it's I've got, I'm, I'm 1.5 million views, or something
Oh,
like that. Oh,
that's
no, it's actually not
cool.
much anymore, but
I know
I
that.
take, so I actually have uh, medical musical parodies on almost all these topics. So check those out. They're kind of fun.
Have to. Yes. And entertainment education, right?
Yeah, yeah,
That's
exactly,
great.
exactly. And I'm tenured and I can do whatever I want.
Yes.
Go
We
tenure.
honestly, let's all just have a tenure attitude, whether we're tenured or not. I think
Yeah,
that's great.
it's yeah, it is. It's easy to abuse that.
Sure. but you're
So you got
obviously
to be
using your
careful.
powers for good, so that's
Yeah,
nice.
exactly.
According to you.
Most people, other than there was this one cardiologist, didn't agree with me, but other, but no, it's a pleasure. And you know what? I love what you're doing. You know, when you contact me, I listened to some of your podcasts and great messages, and you are the exact person we are designed to help.
Mm-hmm. That's great. Well, I'm glad that I found you because it
Yeah.
was helpful. Like one way, honestly, to like spin or like a frame of which of what you do is like through like the wellness preventing burnout thing. Because
Yeah.
the notion of doing less, like focusing in on what's the actual value outside the noise is is so valuable, not only so for like well for just so many reasons, but including like people feel so overwhelmed, and this is like simplified is
Yeah.
beneficial, you know.
It is empowering.
It is
Yeah.
empowering, and so yeah,
And
definitely
and and
keep
and
doing your
and
work.
you mentioned the word wellness, which is a little bit of a, I mean, it's
Very
okay, I
buzz.
guess, but we should
Mhm.
talk about nutrition sometime because that's another thing. I wrote a book on nutrition too.
I saw that book. I am definitely buying that book because
Yeah.
I mean it's a whole issue. Anyway,
Oh,
we'll
it's
get into
there are
this.
so many. Oh
Oh,
my
it's
goodness, you
diet
know.
culture is
Oh,
it's not good. It's not good.
and it kind of it's a thing we will never know.
Mm.
It's hard. How do you know if broccoli is good for you? Well, we'll never do a study. Well, we just don't. Yeah. Anyway, that's another
Yeah.
podcast. So let me know.
All right, well, let's do it.
Cool.
Thank you so much.
My pleasure.
And yeah, for everyone else, I'll talk to you next week.